Welcome to the Lifestar Training and Education Center. My name is Todd. I thank you for joining me today. The topic for today's discussion is antidysrhythmic drugs. Or why can't we just carry, and then you can put the name of whatever your favorite antidysrhythmic drug is right there. Some of your heads are already spinning because you don't like the word antidysrhythmic. It doesn't hit the ear as naturally as antiarrhythmic, and we're used to using the word arrhythmia to describe dysrhythmias. However, if you think back to EMT school or paramedic school when you went over the medical terminology portion of the class, the Latin words that begin with a mean the absence of. Therefore, there is only one true arrhythmia, and that is asystole. But since the rest of the EMS profession, all of the medical professions, and pretty much everyone in the free world still refer to it as antiarrhythmics, I'm just going to jump on the bandwagon and use the word you're used to hearing, and apologize to my paramedic instructor who is such a stickler on this topic. Antiarrhythmic drugs is the largest category of drugs that we carry on the ambulance. We carry more drugs that do that than anything else. Most of us will recognize that hot pink Lidocaine box. This is the pre-filled syringe. It also comes in a drip bag for maintenance infusions. We carry labetalol on the ambulance for hypertension, among other things, but as a beta blocker, it is an antiarrhythmic drug, and the same is true for metoprolol, antiarrhythmic beta blocker drug. Most of us will recognize that little brown bottle of amiodarone we give for VFib and VTAC. It's an antiarrhythmic, as is diltiazem, which we also call cardizem on the ambulance, which we give for AFib. The purple box of atropine sulfate and most of the other drugs are about slowing the heart down. This one is about speeding the heart up, but it is an antiarrhythmic drug. And there's good old epinephrine 1/10,000, which we give in all sorts of circumstances, in all cases of cardiac arrest. Can't forget about adenosine, 6 milligram and 12 milligram. Very entertaining to give. And then there's magnesium sulfate, which we use for a wide variety of things on the ambulance, but one of the things we use them for is a very particular form of arrhythmia called torsades de pointes. So, there are paramedics out there who would say if almost all these drugs are about rate control, and I read somewhere that amiodarone is kind of an all-purpose rate control drug, why can't we just carry amiodarone? Then we only have to memorize one dosage and one drug and one set of indications and contraindications, and we don't have to worry about all this other complicated stuff. Well, to those people, I'd say, settle down, fire medic. Just kidding. Not really. But there are other paramedics out there that would say, I would like to choose the drug that treats the precise problem that this particular patient is having, and by picking the right drug for this circumstance, I'm avoiding the possibility of negative side effects of all the other drugs, and I want to fine-tune my treatment to the circumstance. Those people are called paramedics. So here's an electrical system of the heart. It starts in the sinus node in the upper left-hand corner. When the heart is behaving normally, the rhythm is coming from the sinus node. It's about the size of the tip of a sharpened pencil. Very, very small bundle of tissues. Once the sinus node fires, the electrical impulse travels down the internodal pathways from one node to the next, the sinus node to the AV node. The atrioventricular node then continues the electrical signal through the bundle into the right and left bundle branches and into the Purkinje fibers, where it's distributed to the rest of the heart. So in normal circumstances, electricity is traveling from the upper left-hand portion of this chart to the lower right-hand portion. So in a normal sinus rhythm, Everything is beginning in that sinus node, and when you have a tachycardia, something is happening to stimulate that sinus node and cause your heart to beat faster. It might be the presence of stimulants in the system. It might be electrolyte imbalances. It could be a reflex to hypotension. Somebody is bleeding out, so their heart starts beating faster, or they're hypotensive due to sepsis, hypovolemia. Whatever the cause, sinus tachycardia, the electrical signal is still originating where it's supposed to in the sinus node. For that reason, for the most part, anatomically, the heart is behaving normally, and the cause of sinus tachycardia is usually coming from somewhere else. Here's sinus tach on a monitor, no big deal. We see this all the time. Everything is normal. There are P waves associated with all the QRSs. The QRSs are narrow because everything is depolarizing normally, and it's really kind of a ho-hum rhythm, and we try and treat the underlying causes if we can figure out what they are in order to make the tachycardia go away. We don't use a lot of antiarrhythmic drugs to control sinus tachycardia. Now, if some atrial tissue somewhere besides the sinus node decides it's going to take over the pacemaking function of the heart, because it's irritated, or because there's a structural deformity, or because there's an electrolyte imbalance or an injury, then we have an ectopic atrial tachycardia. Ectopic atrial tachycardia is distinguishable on an EKG by looking at that P wave. The electrical signal is still originating somewhere in the top part of the heart, so you're still getting a P wave, but there's something different about these P waves. And here the difference is an inverted P wave. It might be a different morphology. There could be a bizarre shape to the P wave, but because the electrical signal is coming from somewhere other than where we expect to see it, the shape on the EKG is going to be different. So here's an example of an ectopic atrial tachycardia. Now, if 3 or more sections of atrial tissue all start fighting with each other in order to take over the pacemaking for the heart, because we have a greater amount of irritation to the atrial tissue, then we have multifocal atrial tachycardia. Multifocal atrial tachycardia is a rare rhythm because it's usually transitional between a sinus rhythm and an atrial fibrillation type rhythm. However, if you happen to catch this rare rhythm, it's distinguishable on the ECG by looking for 3 or more distinct morphologies or shapes of P waves that repeat themselves in the rhythm strip. So here I've identified 3 different shapes of P waves, and if you pick one of those shapes and let your eyes wander over that ECG to the right, you will find each one of those shapes repeats itself again and again in more or less a random manner on this ECG strip. If you have 3 or more of those, that's multifocal atrial tachycardia. Now, if the source of the arrhythmia is lower in the heart in the AV node, particularly if an area of tissue just outside the AV node starts reflecting the signal back into the AV node, you get an AV nodal reentrant tachycardia. The signal goes through the AV node, it exits into some tissue surrounding it, and it gets excited and reflects the signal back, and then it fires again, causing this tachycardia. This is what's happening with AV-NRT. The signal is getting reflected right back into that AV node. AV-NRT is one of those rhythms that is pretty subtle, and it's something that all of us are likely to overlook because it's so difficult to spot. This is the kind of thing a cardiologist or an electrophysiologist would notice before we would. However, if you look in V1 here, V1 being the best lead to determine activity in the upper part of the heart, you'll notice that in a normal QRS you have a rounded return to the ST segment, and in AV-NRT you're getting a retrograde P wave. And so there's that little bump that's actually a P wave, but it's occurring after the QRS because the signal is being reflected upward to the top of the heart from this accessory pathway. Again, it's subtle. Most of us are going to miss this. If that electrical signal is exiting the AV node and traveling some distance down the bundle branches, and then it exits the electrical pathway, goes into the ventricular tissue, and gets reflected back up into the AV node, that's an AV reentrant tachycardia, an atrioventricular reentrant tachycardia, which is AVRT. You'll notice here that the electrical signal is leaving the AV node and traveling down the pathway in the correct direction. That makes it orthodromic, meaning in the normal anatomical direction. So an orthodromic AVRT is where the signal travels through the pathway in the correct direction, and then it jumps off the highway and travels backwards up into the top part of the heart again. This is an orthodromic AVRT. It's at a very fast rate here. You're not usually going to see P waves in an orthodromic AVRT because the signal is not getting all the way up into the top part of the heart. Now, if the electrical signal is traveling in the opposite direction of what it should be, because there's an accessory pathway somewhere in the heart, that is an antidromic reentrant tachycardia. We all study in paramedic school about an antidromic AVRT, and that would be Wolff-Parkinson-White. We also study about LGL, which is a different accessory pathway. The distinguishing characteristic for Wolff-Parkinson-White is right here, that delta wave. And you notice that delta wave repeats itself in every one of those beats. It's that little extra triangular segment. And that's the sign that there's pre-excitation of the ventricular tissue. And we all have been taught not to give certain kinds of antiarrhythmics if we are aware of Wolff-Parkinson-White or suspect Wolff-Parkinson-White because of that accessory pathway. You would actually be making things worse and not better. No conversation about antiarrhythmics and tachycardias would be complete without a discussion of action potential. We'll pause for a moment for the paramedics in the room to relive their post-traumatic stress from paramedic school when they studied this topic. Here's a picture of a bubbling brook to help you feel more at home and relax. If you're one of our Adams County providers, here's a picture of a bubbling meth lab to help you feel more at home and relax. So action potentials come in categories of either nodal or non-nodal action potentials. Here we see the nodal cells, as in sinoatrial node and atrioventricular node. And you notice there are three ions that are very important here. We have calcium here at phase 0 in red, and that's the depolarization phase. And then we have potassium at phase 3. Notice there's no phase 1 or 2 here. It goes straight from phase 0 to phase 3, and the potassium is important in the repolarization phase. There is also sodium here at phase 4. Sodium plays a very minor role in nodal cells, and sodium channel blockers don't even affect nodal cells. So they really aren't in play here. We're really mostly concerned with calcium and potassium. Here are non-nodal cells. Non-nodal cells are cardiac muscles, as in atrial muscle and ventricular muscle. And here we have the same three ions that are important, but they're important in different phases. So here sodium is important in phase 0. In the nodal cells, it was calcium. Here, it's sodium. Then potassium becomes important in phase 1 and phase 3. And calcium becomes important at phase 2 in the non-nodal cells. What's happening here is in these cells, we have the movement of these ions across the cell membrane. The cell membrane has these channels that allow the various ions to move in and out. And what we're doing is we're using medications that can target specific channels in order to slow down the movement of either the sodium, the calcium, or the potassium, depending on which part of the action potential we're trying to change. So let's go through class by class and talk about what antiarrhythmics we carry and what they do to the action potential. Class 1 are sodium channel blockers, and they affect the sodium channels in phase 0 in non-nodal cells. So here's the non-nodal action potential, and there's the sodium. Sodium's important at phase 0, which is the depolarization or the contracting of the muscle. And when you add lidocaine, or a sodium channel blocker, to the patient's system, you go from this to this. So you're changing the slope of the phase 0 line from being very rapid to slowing it down. It takes longer to depolarize, and that stretches everything out. That creates a longer effective refractory period, and that slows down the heart rate. As I said, because nodal cells depolarize based on calcium, they aren't affected by the sodium channel blockers. Sodium channel blockers work by decreasing the conduction in the atrial and ventricular muscle and also in the Purkinje fibers. So indications for sodium channel blockers would be ventricular tachycardias and malignant PVCs. We also use it for refractory VFib under the new AHA algorithm. They've added sodium channel blockers or lidocaine back into the mix. So if you're treating the VFib or the pulseless VTAC and the amiodarone isn't working, you can switch to a sodium channel blocker, and that might do the trick. Malignant PVCs are defined as anything more than 6 PVCs a minute. PVCs, or premature ventricular contractions, are usually non-perfusing beats. And since they're non-perfusing, the heart is going through all the trouble of contracting, but it's not moving any blood. And when that happens a lot of times in a minute, you're losing your perfusion, and you want to calm those PVCs down. So we will give sodium channel blockers to accomplish that. So we give them lidocaine, and you'll remember the dosing is 1 to 1.5 milligrams per kilogram. Another interesting thing about sodium channel blockers is they can be useful when there's a reentry mechanism. Under WPW, Wolff-Parkinson-White, or LGL, there is that conduction of electricity through the accessory pathway, and it's not going through the nodes. And since sodium channel blockers don't affect the nodes, it's safe to give a class 1 antiarrhythmic to a WPW or an LGL patient in order to slow things down. Class 2 antiarrhythmics are beta blockers. We're going to chill on that for a bit because beta blockers work differently than channel blockers. So we're going to skip class 2 and go straight to class 3, which are potassium channel blockers. We carry amiodarone in that category. These work on non-nodal cells, and they work by elongating phase 3. So there is your non-nodal action potential. There is your potassium. And when you add a potassium channel blocker, you're going to stretch out that phase 3. So it starts here, and it moves to there. Everything gets stretched out. It takes longer for the repolarization to happen, and that slows things down. One of the risks of potassium channel blockers is elongating the QT interval. So when we are administering amiodarone, and if we're putting the patient on a maintenance drip, we're giving more and more amiodarone over time, we need to be watching the monitor for the QT interval. This is the action potential for non-nodal cells, and there is the depolarization portion. And in this QRS complex, that is the depolarization on the EKG. This is the repolarization in phase 3 of the action potential, which we just stretched out by giving that amiodarone. So how that affects the EKG is right here in the repolarization phase. We give that class 3 antiarrhythmic, the potassium channel blocker, and we're going to extend the QT interval by widening out that repolarization. That's going to move in that direction. If you keep giving more and more amiodarone and you're not watching that QT interval, the risk is torsade de pointe. That's what torsades de pointes looks like, and that's what we're trying to avoid by giving too much amiodarone. If we find that we did accidentally put the patient into torsade de pointe, or hopefully since we're professional providers, we were watching the monitor and we saw the elongated QT interval, and now we want to make sure we shut off the amiodarone, and perhaps we even want to correct the rhythm, that's when we introduce mag sulfate. Mag sulfate is our treatment when we find a patient to be in torsades, but we can also use it to prevent torsades if we notice that QT interval elongating too long. Mag sulfate is a class 5 antidysrhythmic. That's the other category. And it's actually a calcium channel blocker, but it's blocking the calcium in the other direction. So here we have the elongated phase 3 because we gave a potassium channel blocker and it's getting longer and longer, and oops, we want to shorten that up. So we're going to use that mag sulfate, and you see at the top there, calcium is important in phase 2. So when we give the mag sulfate, what it's going to do is move from this to that. So phase 3 is still elongated from the potassium channel blocker, but we just gave mag sulfate to move it from this to that. Class 3 antiarrhythmics are indicated for VFib and VTAC in the AHA algorithm. And it can also be used in SVTs because you'll remember this works on non-nodal cells and it slows down the repolarization, and that can affect the atrial tissue just like it affects the ventricular tissue. However, in our treatment guidelines, SVTs, we generally go to adenosine or electrical therapy if it's an emergency. And that brings us to class 4 calcium channel blockers and good old diltiazem. Calcium channel blockers work on the nodal cells. There's the nodal action potential, and you see there calcium is important at phase 0, which is the depolarization phase. Nodal cells include the sinus node and the atrioventricular node. Sinus tachycardia, again, we don't very much address the rhythm itself. We address the underlying issues that led to the rhythm. So sinus tachycardia we don't worry about. So this is mostly about addressing or targeting the atrioventricular node. The atrioventricular node is important in AFib with rapid ventricular response. So this is an animation which shows what happens when we use calcium channel blockers to correct for AFib with rapid ventricular response. In the upper left-hand corner, you see the atrial tissue is quivering with all this electrical activity. That's happening with all AFibers all the time. But the problem is those signals are going through the AV node too often into the ventricles, and the ventricles are responding to all those additional signals, and they're firing too quickly. So we add a calcium channel blocker, that's those black dots crossing the AV node, which is going to filter out some of the electrical signals that are coming from the top of the heart and traveling down into the bottom of the heart. And that is how calcium channel blockers reduce the rate in AFib RVR. So here is the nodal action potential. And there's where calcium is important at phase 0. And so we're going to start with this action potential, and when we slow down the calcium, we're going to change it to that. And that spreads things out, and it takes longer for signals to travel from the top to the bottom. So starting there and stretching it out with the class 4 calcium channel blocker. And that brings us back to class 2 antiarrhythmics, the beta blockers. Now the beta blockers work on the nodal action potential by lowering the slope of that mustard-colored line down below the threshold in the action potential for nodal cells. So by lowering that slope, you're going to widen everything out like this. Before and after. And I'm sure some of you are remembering, but you promised that they work differently than the channel blockers, and this looks just like how the channel blockers work. And that is true, they do work differently because beta blockers are sympatholytic. Sympatholytic is a fancy word for saying they destroy the effect of sympathetic nervous system action. Sympathetic nervous system is the epinephrine and norepinephrine, which stimulates things. Beta blockers compete with norepinephrine and epinephrine by binding with their receptor sites in nodal cells, but also in cardiac muscle cells and conductive tissue. So they are slowing things down everywhere, not just in the nodes. Most beta blockers are selective, meaning they're not beta 1 and beta 2, they only select for beta 1. And you remember how to differentiate between beta 1 and beta 2? We have one heart, we have two lungs. So beta 1 is heart-related stuff, and beta 2 is lung-related stuff. So what about those other drugs that were in the list at the beginning of this discussion? Well, adenosine works on these channels that you see the sodium and the potassium running through. Those myocardial cells and the nodal cells, in fact, all the cells in the heart have these channels that the sodium and potassium are running in and out of. And if we zoom in on one of those channels, we'll see there's a machine that moves the sodium and potassium where it needs to move. And that machine is called the sodium-potassium pump. And the fuel that it runs on is adenosine. So that sodium-potassium pump is moving sodium out and moving potassium in until the charge gets to a particular setting, which would be negative 90 millivolts, and then boom, suddenly the channel is open, and then that sodium-potassium pump starts working all over again. When we flood it with its fuel, adenosine, what we get is no activity at all for a while, and that's why you see asystole when we give adenosine to a patient. Adenosine tends to burn off very, very quickly. That's why 6 milligrams frequently doesn't work, because it burns off before it even gets to the heart. So then we switch to 12 milligrams and see if that'll work. So that asystole is not permanent. It's going to go away very quickly as soon as the adenosine wears off. And that brings us to atropine, the last drug on the list, and the only drug here whose job it is to speed things up instead of slow things down. Atropine works based on some of the physiology that occurs with the vagus nerve. The vagus nerve innervates the heart, and it releases acetylcholine, which attaches to receptors in the nodal cells. And the job of acetylcholine is to slow things down. It puts the brake on electrical activity, and it makes everything run more slowly. Atropine competes with the acetylcholine by binding to the same receptors, and that will temporarily take the brake off, and that causes things to begin happening faster. And that's how atropine works. Now that we've talked about a number of arrhythmias that we encounter in the ambulance and the antiarrhythmic drugs that we use to treat them and how those drugs work, it's story time. So this first story, which is a true story, I like to call 100 milligrams lidocaine rapid IV push. It's a story of misdiagnosis, loss of focus, and panic. Just kidding. not really. This is a 911 call that happened in another county, and I am engaging in forensic paramedicine. What I'm doing is reconstructing what happened on the call by taking a look at the code summary and putting together all available evidence to figure out what was going on with the patient, what was going on in the mind of the paramedic, and trying to figure out what happened and why. It's kind of a little detective work. I love doing this stuff. It's a problem-solving exercise, and I really learn a lot by going over this kind of information and filling in the blanks. You'll notice the subtitle here is Panic and Tunnel Vision in the Emergency Medical Setting, so there's a little bit of drama involved in the call too, which is always entertaining. So this is a call that happened in October of 2013. I happened to be listening to the radio at the time, so I heard the call unfold as it was happening. And then I obtained the code summary to kind of put the pieces together after the fact as well and reconstruct. This is a 911 call in a paid-on-call fire department. It's an ALS department, paramedic level, and the call is for weakness. While on scene, you can hear one of the EMTs get on the radio to the local hospital, and they issue a stroke alert. And then the fire department began transporting the patient. They did go lights and sirens, which is department policy for any suspected stroke. And then you hear the paramedic get on the radio in the back. You can hear the sirens going, and the paramedic calls the hospital and asks for online medical direction. So the call for medical direction begins with requesting the hospital's attention, and you hear a female voice get on the radio and say, "Go ahead with your request," and the paramedic says, "I need to speak to the doc." A couple seconds go by, and then you hear a female voice, may or may not have been the same person, say, "Go ahead with your question." And then the paramedic, in a very sarcastic tone of voice, says, "Are you the doc?" And that's when I turned up the volume of the radio because I wanted to hear how the rest of this conversation was going to go. So the voice says, "Yes, go ahead with your question. This is Dr. So-and-so." And the paramedic says, "Did you get my 12 lead? Did you get my 12 lead?" Just that tone of voice and with that much of a pause between. So there's a little bit of silence coming from the hospital, and then you hear the doctor say, "I got what you sent me. Go ahead with your question." That's going to be an important clue to what's going on with this call. So the paramedic then says, "We have this patient that we thought was a stroke alert, and I'm looking at the cardiac rhythm, and I'm seeing several extended runs of wide QRS complexes. I would like to give 100 milligrams of lidocaine rapid IV push for ventricular irritability." You hear a few seconds go by, and then the doctor answers, "No, let's not give the lidocaine right now." And the paramedic then gets on the radio and says, "Okay, so it's okay to go ahead and give the lidocaine?" And then the doc, in a very exasperated voice, says, "No, don't do anything else to this patient. Just bring her here." And that was the end of the conversation. So I really wanted to see what the paramedic was seeing on the monitor to figure out why 100 milligrams of lidocaine rapid IV push would be appropriate. Here we see lidocaine in the standard pre-filled syringe. It's 100 milligrams, which is an easy dose. The dose for lidocaine for the non-ALS people is 1 to 1.5 milligrams per kilogram. Generally, it's for malignant PVCs and ventricular irritability. But the paramedic is talking about several extended runs of wide QRS complexes, very much making a case for ventricular tachycardia, or VTAC. And the paramedic is asking for rapid IV push. Paramedics generally are cautious about giving lidocaine because lidocaine, as you know, can reduce the sensitivity when it's a numbing agent when it's used topically. It's what the dentist injects into your gums in order to work on your teeth to kill pain. And it does the same thing to the heart. So when you're going to give a medication to numb the heart, you want to be careful about that. And some of us have had the experience when you give lidocaine that the heart rhythm changes. And you also have the experience sometimes the patient will begin to crash. So we generally give it slowly so you can turn it off, and we'll give it in a piggyback setup. And you see a piggyback here in which you would have on the left maybe a liter of normal saline running, and on the right you would have the lidocaine running, and if anything happens you can immediately shut off the lidocaine and turn up the saline in order to bring pressure back up. It's just a good cautious way to give it. 100 milligrams of lidocaine rapid IV push is an incredibly aggressive and reckless way of giving lidocaine to a patient that's experiencing a cardiac event. So let's take a look at the code summary and see what we can learn forensically after the fact. So here we see a patient that's 79 years old and female, and I circled the pressures over on the right, 143 over 107 with a heart rate of 78, and down in the lower right, 137 over 54 with a heart rate of 96. So this right at the moment, based only on this evidence, is presenting as a patient that appears to be hemodynamically stable at the moment. So here we see at 2134 the initial rhythm. That's when they first put the 4 EKG electrodes on the patient, the first rhythm that's analyzed by the monitor. It generally will gather an 8-second strip immediately after the electrodes have been applied. This, by the way, is a LifePak 15 monitor, which is good to know because we understand some of the characteristics of the LifePak 15 and what it does and why it does what it's doing. Down here we see the first 12 lead at 2137, so that's only 3 minutes after the initial rhythm is obtained. Someone pressed the 12 lead button. Down here we see that whatever that 12 lead looked like was transmitted to the hospital at 2140, 3 minutes later. And then we see that we have at least 3 more 12 lead attempts, one at 2141, one at 2145, and one at 2148. So we're getting sequential 12 leads just a few minutes apart for some reason. And if we go to the second part of the code summary, you'll see we do have one more pressure of 154 over 125. Diastolic's probably a little suspicious there. And then a 5th attempt at a 12 lead. So that's 5 12 lead attempts in about a 20-minute period. Let's take a look at the code summary. There was certainly a lot of information in that code summary, and I left the code summary intact so you could see that nothing was edited out of it. So did you catch what was missing from that code summary? If you did, well done. You might have noticed that there were no 12 leads anywhere in that code summary, although we know there were 5 attempts at obtaining a 12 lead. That's an important clue as to what was going on in the back of that ambulance. It also explains why there was miscommunication with the hospital. And most importantly, it shows that the paramedic didn't have all the information he should have had at his disposal. Let's find out why that happened. So, we noted that no 12 leads appeared, and if you look at the box at the bottom, you'll notice that the ECG override function on a LifePak 15 says when you try and get a 12 lead, if there's a lot of noise or excessive data, it's going to not run the 12 lead, and it's going to give a warning to the user. It's going to say noisy data, press 12 lead to accept. And that message will remain until one of two things happens. It'll remain until all the noise goes away and it can get a good clean 12 lead, and then it'll go ahead and take that 12 lead. Or if the paramedic wants that 12 lead right away and is willing to tolerate whatever artifact or noise is going on, you can press 12 lead button again and it'll run that 12 lead for you. If neither one of those two things happen, at the bottom it explains that if the signal noise persists for longer than 30 seconds, it's going to give up on getting that 12 lead. The screen will say excessive noise, 12 lead cancel, and then you have to start all over again in order to get that 12 lead. So this is the initial rhythm that was obtained at 21:34. In the upper left I circled lead 2, so that's the lead that we're looking at, and that is just kind of an ugly, disorganized rhythm. You're not really entirely sure what's going on. At the tail end, you're seeing some wide QRS complexes that look a little bit like a left bundle branch block, and so that ST segment elevation over there, it actually, if you apply Smith and Scarbosa criteria, might be STEMI, but it would need, this is non-diagnostic, this is only lead 2, so you can't scream STEMI just yet. In fact, it's never going to be a STEMI, so you can take that off of your index of suspicion. But this is the initial rhythm. So as soon as those 4 wires were put on the patient, there's an 8-second strip that the LifePak prints out to show what the first look at cardiac activity is. The next thing in the code summary is a print, and the print at the top there means that the paramedic pressed the print button. And on a LifePak 15, when you press the print button, it'll capture whatever was going on for 3 seconds before you press the button, and then for 5 seconds after you press the button, in order to capture whatever it is the paramedic was trying to capture. So there in lead 2, we're seeing some different morphologies. Morphology meaning, of course, the shape of the ECG. You're seeing different morphologies going on here. You got this kind of ugly, disorganized stuff in the very first circle, and then you see kind of a left bundle branch thing happening, or a PVC thing happening in the second circle. And then the third, you see a regular morphology, 3 of them in a row, that looks kind of like that left bundle branch kind of thing going. And then you go into kind of a very disorganized, ugly rhythm. And then at the very tail end, it almost looks like you got some 60 hertz interference with some ugly stuff happening after it. Definitely a what is going on here kind of situation. So in this next box, we have a check patient. On a LifePak 15, if it sees a dramatic change in the cardiac rhythm, it prints out a check patient strip, which is 8 seconds of whatever it was seeing immediately prior to the check patient. So whatever this rhythm is, the LifePak wants to bring it to the attention of whoever's in the back of the ambulance and say, hey, look, what we've been looking at is very different from what we're seeing now. You should take a look at this. And check patient is also an indication that maybe you need to check for a pulse, because this may be a pulseless rhythm. The next box is another check patient, so something happened in this rhythm that caused the monitor to want the paramedic to take a look at the patient, make sure the patient still has a pulse. And then also there's something different going on in this 8-second strip that the monitor wanted to bring to the attention of the paramedic. And I'm going to indicate here, I'm going to give you a second to stare and see if you can figure out what it is the monitor wanted the paramedic to see. If you look at this strip again, you'll notice something new has entered into this whole equation. We see some arrows. Those arrows are how the LifePak indicates that there are pacer spikes happening somewhere in the rhythm. They're very occasional, It could be artifact, it could be road noise, but it looks to the monitor like a pacer has started firing, and it's firing in a very inconsistent way. You have one firing about 3 seconds in, and then about 6 seconds in, you have this double bang on the pacemaker. Just kind of weird, and it might be something that you'd choose to just kind of wait and see if it happens again, because it's not a very reliable, just a few blips here. But that is the reason why the monitor wants to get the attention of the paramedic. So now we have another check patient. It's 2142 now into the call. Now we're seeing some more frequent firing of those pacer spikes. So now you're beginning to suspect that there's something going on here. We're not really seeing changes too much in the morphology of the rhythm. It's still in lead 2 an ugly wide QRS complex rhythm. It's predominantly negative in its deflection. It's below the isoelectric line, but you got some weird stuff happening here, and it's definitely should be raising some eyebrows about trying to figure out what is going on with this call and what is going on with this patient. So here, it's not a check patient, it's a print function. So print again is 3 seconds before the paramedic pressed the button and 5 seconds after. So you're looking at the screen here and thinking, what is it the paramedic saw that caused him or her to press this print button to try and capture whatever's going on in the monitor? Remember, you're looking at the monitor screen, you're not looking at the paper. And printing is to capture what you're seeing on the screen. So here we see, I just put a big arrow to show one of the morphologies that's going on. But look at the bottom with the pacing spikes. Now the pacer is firing much more frequently, and the result is a very even, consistent morphology of a ECG, a QRS complex here. It's a wide QRS. Probably doesn't meet Smith and Scarbosa criteria. Again, it's not diagnostic. You have to do an actual 12 lead to talk about the ST segment. But this is very much looking like a paced rhythm, right? We've all seen that on the monitor. It's wide QRS complexes. There's usually a rebound where the ST segment is far above the line. Because of that rebound, the QRS dips so far down that when it comes back, it rebounds high. And this is what the paramedic was looking at on the screen that he was trying to capture. This is also about the time that the paramedic called in asking to give 100 of Lidocaine rapid IV push. Again, though, what is the paramedic actually looking at? Is he looking at the printout, or is he looking at the screen? Just knowing how I work with monitors and how other people work with monitors, when you're just pressing print, you're usually not pressing print in order to look immediately at the paper. You're just trying to capture that for the record of whatever it is you're seeing on the screen. So now we have another print, again 3 seconds before and 5 seconds after pressing the print button. That little down arrow shows exactly when the button was printed. And here I'm pointing out different morphologies of rhythm. So this may be what the paramedic was trying to capture, was the change in rhythm. And then it goes back to that paced rhythm again. So for a while we have these weird, ugly, low voltage QRS complexes followed by a nice, big, consistent paced rhythm. And again, you see the pacer spikes indicated at the bottom of the printout. Here's another print pushed by the paramedic 3 seconds before and 5 seconds after. You have pacer spikes. They're kind of uneven at the bottom, but then you have mostly this wide QRS complex, typical paced rhythm. Here's another manual print pressed by the paramedic, and again you have wide complex QRS and lots of pacer spikes at the bottom, very irregularly placed. So let's really dig in and analyze what was happening on this call. So first of all, on this call, no 12 leads were actually performed. The button was pressed a number of times, but because of the tunnel vision and not paying attention to the monitor, no 12 leads were actually obtained. And since no 12 leads were performed, no 12 leads were transmitted. That kind of explains the confusion in calling medical control and asking, did you get my 12 lead? And the doc having to look around and figure out, first of all, did they send a 12 lead? Or the second question might be, why doesn't this paramedic realize what I'm looking at is not a 12 lead? So there was the delay in the doctor's response, and then the irritation on the part of the paramedic, which clearly was not justified. Pressing print could have provided a clue of pacer spikes, but the paramedic actually has to look at the printout. And as I said before, frequently when we press just print because we're looking at the screen and seeing a rhythm, all we're trying to do is capture this on paper for later reference, and we're not really planning on taking that printout and looking at it immediately. Had the 12 lead been done, then the behavior of the paramedic usually changes, because when you have a 12 lead, you want to rip that 12 lead off and actually interpret it, and then the pacer spikes would have been evident, and hopefully this paramedic would have seen the pacer spikes and maybe put two and two together as to what's going on with these QRS complexes. But because we didn't have those pacer spikes, the paramedic misinterpreted this rhythm as VTAC, and seeing VTAC on the monitor is kind of one of those oh my goodness moments. And again, we had tunnel vision. Paramedic decided what was going on with this patient and didn't look at all the available evidence, and also didn't ask the question, am I right in my conclusion? And good paramedics aren't necessarily the aggressive ones that choose the most advanced treatments. Good paramedics are the ones that question their decision making and reevaluate what's going on while the patient is still in the ambulance. The treatment guidelines would have called for 150 milligrams of amiodarone over 10 minutes for a stable VTAC, but this paramedic was asking for the more exotic or more aggressive treatment of 100 milligrams of lidocaine, and not just 100 milligrams of lidocaine, but as a rapid IV push. So, what was wrong with this patient? Looking at the preponderance of evidence, the chief complaint of weakness, and the initial rhythms with that weird native beat, and then the changes in rhythms and the coming and going of the pacer spikes, the most likely explanation is there's something going on with the cardiac pacer. And in fact, a follow-up with the hospital did reveal that this was a patient whose pacer was failing to capture electrically, and it was failing to fire altogether. And so the patient was sent up to the OR and they replaced her pacemaker, and the problem was solved. So I would leave you with this very important question that this paramedic will never know, because I don't know if the paramedic ever followed up and learned what was wrong with the patient. But what would have happened if 100 milligrams of lidocaine were given rapid IV push to a patient whose native rhythm looks like this? This is a case study that gives us the opportunity to discuss the administration of magnesium sulfate, in particular how to do a little bit of problem solving and figuring out how you're going to get the mag sulfate into the patient. This is an emergency interfacility transport of a 60-year-old male, and you'll notice in the upper right-hand corner, the primary impression is cardiac arrhythmia, the secondary impression is a stroke, chief complaint of right-sided weakness, with a secondary complaint of a headache. The signs and symptoms that were noted by the crew are in two categories. Under cognitive functions and awareness, they found attention and concentration deficit. And under the cardiovascular category, they found AFib and some other cardiac arrhythmia, which we will see in a moment. So here's the narrative, which is a great way to get an overall picture of what happened on the call. LifeStar was dispatched code 2 to AMC Washington County for a patient transport to AMC Grafton for a patient with a possible stroke and cardiac dysrhythmia. On arrival, the 60-year-old male was found lying semi-Fowlers in the ED bed, AN04 GCS15, good ABCs. This is a sentence that causes a great deal of confusion for me. They say the patient was seen for a possible stroke at 1800 and a fall with right-sided weakness, did not arrive in the hospital until after midnight. That's a 6-hour difference. And it isn't clear what you mean by the patient was seen. Seen by whom? Were they in a nursing home and they were seen by a doctor there at 1800, but they didn't get sent out until later? Were they seen by EMS and they took a cancel? There's just no way to know what's going on here. The reason why it's important is because we need a last known well time on a patient with a stroke. I don't see last known well time anywhere in this narrative, and so this would be the first place to get a clue as to when the onset of symptoms occurred. He had a fall at 1800, or possibly had a fall at 1800. That's when he was seen, but we don't have the full story here. So here's an opportunity to be a little more clear. Now, granted, this is a 4 a.m. call, and this is a report that's probably being written at 6 a.m. at the end of a long shift. So maybe things are a little groggy in the head of the person writing the report, and I get it, and that's definitely understandable. But you have to write your reports with the idea that somebody's going to be reading it who wasn't there and is going to try and answer some questions from the details provided in the report, and it's just missing in this one. Continuing with the narrative, the patient CT was negative. They were found in AFib with frequent PVCs. The MAG levels were low as well, and they've been placed on a 2-gram mag sulfate infusion. And here's your secondary complaint. The patient complained of a headache, constant, at a 2 of 10. The assessment section here is not particularly detailed, but it's also not extraordinarily lacking in anything. Their pupils are pearl, skin is warm, pink, and dry, no shortness of breath, difficulty breathing, good CMS in the uppers and lowers bilaterally. And then here's an important contrast. The reported to EMS of an unsteady gait in the ED, which is what the sending RN told them, and then the crew finds no noted weakness in extremities. That's a good compare and contrast there. Patient vitals taken on scene as charted. 12 leads shows AFib with high frequency bigeminal PVCs. That's going to be interesting to see. Patient had 2 20-gauge IVs, one in the forearm, one in the AC. That's terrific detail. The mag sulfate infusion continued at 25 milliliters per hour. That is a really small number. Those who are AEMTs and paramedics will probably remember that TKO is 100 to 120 roughly, and 25 is just a tiny, tiny infusion rate. So I'm curious if that's a typo or if it is a highly concentrated mag sulfate that has to run that slow. Or was this a piggyback infusion, 25 milliliters an hour on the mag part, dumping into a faster rate for the piggyback? I don't know. It isn't here, so there is some missing information there too. And the infusion finished at 5:25. IV was flushed after the infusion was finished. That's good detail because some of us remember that mag sulfate can be very irritating even in a diluted form, so you would want to flush that IV as a patient comfort. And then the last paragraph is a yada yada, status remains unchanged, transfer of care, yada yada. Okay, so let's take a look at this initial assessment. There are 2 sections on the initial assessment that kind of raised my eyebrows. One is the head and the face went unassessed in a stroke patient. I would think you would want an observation in there about whether or not they had facial droop, but that's an opportunity for improvement. And then in the abdomen section, under general, it says not assessed, but under the 4 quadrants, it looks like perhaps the patient was palpated. Well, it's a stroke/arrhythmia call, so I'm not sure why there would be palpation of the abdomen. So I'm guessing the person writing this report just wanted to indicate they didn't notice any problems in these quadrants and they were going for all 4 quadrants. That, to me, with the no guarding element in there, that means you palpated. So I think a much better way of saying no belly problems on this guy is under the general assessment, just say no abnormalities in that section. I will frequently ask a patient, any belly pain? Are you nauseous? Any trouble down there? And if they say no, under general, I'll say no abnormalities because I asked about it. And it wasn't a call that required palpation or direct examination of the abdomen. All the way at the bottom there, you'll see under neurological, there's an other with expressive dysphagia listed. That's a terrific observation to put in there. Really important. It's an indicator of how obtunded the patient is secondary to this stroke. We saw that in the narrative that the gait was reported to be unsteady, but the EMTs did not find unsteadiness on their examination. So it's important to include this, that even though their arms and legs might be normal, we do have some obtundedness from this CVA that might be going on. Here's the first of 3 12 leads that were done on the call, and it's terrific that we have serial 12 leads both for comparison and because we know we had an arrhythmia that we want to monitor. In this first 12 lead done at 4:02 a.m., you'll notice the limb leads are a little squiggly, lots of artifact. That's where you're going to get it with the limb leads because that's where the patient's moving. It would be nice to have a little cleaner tracing, but we're getting the basic elements here. It's not a highly irregular rhythm, but over in V4, 5, and 6, you'll do notice that's where you see some irregularity. And we don't see any P waves that are obvious throughout, so it's looking like an AFib to me too. At 4:15, I'm guessing we're bouncing down the road at this point because the artifact is greater. I see PVCs over on the left. I see some in the middle. And then over to the right, I'm seeing PVCs as well. Are we worried about this? Well, it's in V6, and V5 and 4 are looking pretty straight and normal, so chances are that's just your road rhythm. Here is the third 12 lead of 4:28. We have pretty much a repeat of the first 12 lead except for this section, in which we are seeing bigeminal PVCs. The QRS complex, followed by a PVC, and the next QRS complex, and followed by the PVC again. But this is a very short time period to be noting bigeminy, and it really would be better to have a rhythm strip. You know, that's where you get the 8, 10, 15, 20 second long strip where it's much easier to spot rhythms like bigeminy. And we don't have any rhythm strips attached to this report, so that would be an opportunity for improvement as well. Here under the history section, we're seeing unable to obtain. This is a very significant trend among people at LifeStar to simply say unable to obtain. And frankly, I just don't believe you. I would expect you to say one of two things in this section. If the nurse handed you the paperwork for this interfacility transport, I expect you to go in and read the paperwork and put the history in there. However, out of this hospital, I am frequently handed an envelope and they tell me the history is in it, and then it turns out it's not in it at all. And that happens a lot coming out of this facility. In that case, I would not say you were unable to obtain and then not document it anywhere else. And since we've already read the narrative and we know it isn't in there, you're going to have to put it in this section. So under medications, allergies, and history, please select other, and then under the note, say no information was provided by the sending RN. I like to do that for two reasons. One, I'm explaining why my patient care report doesn't have basic information about the patient that is required in a patient care report. And second, I am very clearly indicating who is responsible for that lack of information. The sending RN was asked for the information, and she basically refused to give it to you. Many of my reports out of this facility look just like that for that reason. I always ask, are the patient's history, allergies, and medications in this paperwork? They usually say yes, and they're frequently incorrect about that. Okay, off the soapbox, moving on. Under vitals, we see 3 sets of vitals.
that are all more or less stable, no significant deviations there. And then under the EKGs, we have 3 of them. Thank you for doing serial EKGs. And then the notes are terrific there, where you see that they're bigeminal PVCs, or PVCs bigeminal when PVCs are active. And at the bottom you have the IV therapy, the mag sulfate infusion, finished at 525. It's great to put that detail of when it was finished. 2 grams, again, we're not seeing anything about the rate or the concentration, and those would be good details to include on an infusion like this. I also note that under an altered mental status, a blood sugar is something that would be required by our interfacility guidelines. I'm guessing there's some blood work that came along with this patient, and the glucose was in that blood work, and it would be completely legitimate in a non-diabetic patient to put that blood sugar down in your set of vitals to show that we're aware that the altered level of consciousness is due to something other than hypoglycemia. So my feedback on this report so far, I'd like to see more details on the administration of the mag sulfate. The serial 12 leads were great. The rhythm strip to go along with the 12 leads would make them even better. And this is a stroke call, but I didn't see any NIH score mentioned and no Cincinnati stroke scale done by the crew in the absence of the NIH. And then there's that glucose again. So if you don't have an NIH from the sending facility, you should be doing a Cincinnati stroke scale. I'm guessing they did an NIH, and unfortunately at 4 a.m. sometimes it's hard to remember to ask that question, but we do want to ask on stroke patients, what was the NIH? And then document it. Now that brings us to everyone's favorite topic of medication math. Here is our interfacility protocols with regard to the administration of mag sulfate. And you'll remember from the call, 2 grams was the magic number that they were being given. So if I were confronted with the problem of a patient that needs 2 grams of mag sulfate, and coming out of this hospital, I would want to double check how they're giving the mag sulfate. So I would look for guidance. And if I couldn't remember by heart, this is what the reference I would look to, the interfacility protocols, and my eyes are drawn to this section, which you have the same dose, 2 grams, and you'll see it's given over 20 minutes. So we can expect that this is a relatively safe way of giving 2 grams of mag sulfate. So even though it doesn't fit our categories of eclampsia, asthma, or torsades, at least we have a good administrative rate for 2 grams. So here's the mag sulfate that we carry. We carry a 50% solution. Sometimes they're bigger bottles, sometimes they're smaller, but they're all 50% solutions. You see that right here. And we have 25 grams in 50 milliliters. Now, some people can just, in their mind, their brain immediately tells them, oh, that's a half gram per milliliter. Not everyone does that math that quickly, and not everybody thinks in that way. And it's important for you to find the way of thinking about medications and doses that your brain wraps around the best. So we're going to talk a little bit about some medication math, because right there it says it has to be diluted before IV use. So we can't just drop out of the bottle and give it to the patient IV. We got to dilute this stuff. So the first problem is, how are we going to figure out how to get 2 grams out of these bottles? This is not a weight-based dose, so this is not a milligrams per kilogram per minute type formula. So the formula we're going to use is fluid over time. And what that means is we're going to figure out what the exact dose is. We're going to take 2 grams out of this bottle, and we're going to put it into some amount of fluid, and then figure out how to give that fluid over 20 minutes. So we're going to have an exact dose in the bag that we're mixing up. And however much fluid is in that bag, you give it all, because the whole dose is in the bag, and we're going to give it over 20 minutes. So the first question is, how much of this mag sulfate is 2 grams. How many milliliters do we need to draw up? Some people in their head are able to figure that out. Some people like me need to do the cross multiplication. So the bottle on the right there says 5 grams in 10 milliliters. And that's the bottle we carry on our ambulance. So that's one fraction. But we want to give 2 grams. So the question is, if 5 grams are in 10 milliliters, 2 grams are in how many milliliters? And those two fractions have to be equivalent. And if you have equivalent fractions, you can cross multiply them. You start by saying 2 times 10 divided by 5 will get you that last missing number. Again, 2 times 10 divided by 5 gets you the missing 4 milliliters. Did you figure that out yourselves? You'll have a chance to do this again in a minute. So now we know out of that bottle, any one of those bottles this works, but out of the bottle on the right that we carry, pulling up 4 milliliters gets you your 2 grams of mag sulfate.
Ta-da! 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 Ta-da!
So now we need to do our fluid over time calculation. We're going to take those 4 milliliters and we're going to put them into a bag or a syringe that has some amount of fluid in it. Let's say a 250 milliliter bag. So that means it'll really be 254 milliliters. That's not important. So we're just going to put it all in that 250 bag. Okay? So 250 milliliters in 20 minutes is how many milliliters in 60? And we need to do this because our pumps work by the hour, not by the minute. And so that 60 minutes is 1 hour. So we're asking the question, how many milliliters per hour or per 60 minutes are we going to have to set our pump for in order to get this 250 in 20 minutes? So we're going to cross multiply. 60 times 250 divided by 20 gets you that last missing number. 60 times 250 divided by 20 gets you how much? I'll give you a minute to do the math yourself. And the answer is 750 milliliters per hour.
Ta-da! 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 Ta-da!
Very good. So now the question is, that's 750 milliliters an hour. Does that sound problematic to you? Well, the report said they were both 20 gauge. One was in the AC, one was in the forearm. You can do 750 milliliters an hour in a 20 gauge, but it wouldn't be unusual for the pumps to start complaining that you're trying to push too much fluid through too small of a catheter in too short a time. So, how else can we give this that we wouldn't have to set the rate quite so high? What if we take that 250 bag and change it to 100? Now you could do this in a really big syringe, or you could do this in a 250 bag that you remove some saline from, or you could ask the nurse at the sending facility, hey, could I have 100 bag of normal saline so I can mix this stuff up for you? So now the cross multiplication isn't 60 times 250, it's 60 times 100 divided by 20. And what's that going to give you for a milliliters per hour setting on our IV pump? 300 milliliters an hour. And that's a much more doable number.
Ta-da!
You thought I was going to do the minions again, didn't you? All right, I believe I've done enough damage for 1 month. I really do appreciate you joining me and going over this material. It shows a real commitment to learning and education and keeping your practice at the cutting edge. I hope you stay safe out there, and we'll see you next month. Ta-da!